It's just a general consensus that this $50 billion of funding, it's more of a Band-Aid. It doesn't cure the problem that we have in rural America.
Especially if you're talking $50 billion, and there are 50 states, that's only technically $1 billion a state, which when it comes to healthcare.
Hillary,
I know. Look at that, right off the top of my head.
oh my gosh, I
quick
wouldn't
math.
even.
I did.
Quick math.
There's a recurring theme in every episode we do about healthcare, and it goes something like this. This stuff's really complicated.
Listen, we didn't say it was an earth-shattering theme. Anywho, the recently created Rural Healthcare Transformation Program is no different. In fact, there's so many moving parts, we had to break this episode into 2 episodes.
Shareholder and CPA Kelly Klein, longtime pod listener, first-time guest, explains how the program came to be, how the funds are being distributed, and what rural healthcare facilities need to know.
Whether you're part of a rural healthcare facility, receive care from one, or like to keep up on the ever-shifting healthcare landscape, there's something for you. Listen in to learn more. Welcome to our podcast, Kelly Klein, one of our newest shareholders, and we are talking about a topic that just sounds like so much fun, rural health transformation funds.
Yes.
So tell us what rural health transformation funds are. Tell us how we got here and where we are.
All right, so let's go back to last summer when our administration was putting together their budget. Within that budget, there were a lot of talks about cutting Medicaid, the Medicaid program significantly, and the Affordable Care Act subsidies. So a lot of this funding stemmed from the cuts to Medicaid. So little history. What is Medicaid? Because sometimes people forget what's Medicare, what's Medicaid.
Totally fair.
Frequently confuse the two. They
Sound very similar.
It could have called them something totally different. It would have been great.
So Medicaid is a joint federal and state funding program. It provides free or low-cost health care to low-income families, children, pregnant women, elderly, and the disabled. So a lot of really important areas that need funding. So the administration wanted to cut that funding a little bit. The lawmakers in Congress were really upset by that. So at the last minute, in terms of like political last minutes, they threw in this thing called the Rural Health Transformation Program, $50 billion of funding. And you're like, you hear that number and you're like, wow, this is amazing. Like, I should feel grateful if I am a rural healthcare facility. Like,
Sounds like a ton of money. $50 billion.
of money. Yes. So keep that number in mind. What does this Medicaid defunding represent? So right now, Medicaid services roughly 1 in 4 rural Americans. So that's a lot. That's a lot of people that receive Medicaid funding. So when you cut a program like that, what does that mean in terms of dollars? There's an organization out there that does a lot of like political polling surveys, and they said that they're estimating that this Medicaid funding will cost the Americans roughly $137 billion over the next 10 years.
Holy cow. So we're talking $50 billion, and all of a sudden we're talking $137 billion.
You do not have to be an accountant to do that.
I can do that math. That is almost 3 times as much.
The question is, are we winning or are we losing? And I feel like the answer is obvious.
One
So
of those numbers is bigger.
one of those, yes, that's all you need to know. Which one's bigger and which one's smaller. So I feel like when this Rural Health Transformation Program was introduced into the bill, the OB3, another acronym, One Big Beautiful Bill Act, a lot of the lawmakers and the administration wanted everybody to feel a little bit better about these Medicaid cuts. So even though we're going to take a lot of money away from you, we're giving you $50 billion. Right. Be grateful. And
Don't complain about this.
we are grateful for that, but it has been a lot of concern. So over the last year, since this has really come into a topic of conversation, there have been a lot of concerns from each state individually about this funding. And while the Medicaid cuts hurt, it's just a general consensus that this $50 billion of funding is not really, it's more of a Band-Aid. It doesn't cure the problem that we have in rural America.
Especially if you're talking $50 billion, and there are 50 states, that's only technically $1 billion a state, which when it comes to healthcare.
Hillary,
I know.
you.
Look at that, right off the top of my head.
Oh my gosh,
some
I
quick
wouldn't
math.
even.
I did.
Quick math. So let's get into the numbers then. $50 billion. I feel like I still can't wrap my mind around what that even means. But I think, in governmental budgeting, that's really not a whole lot of money, right?
Now, when you're talking about a budget that's trillions of dollars, the bees get a lot smaller.
Yes, exactly. So $50 billion, what does that mean? The program is going to work like this. So $50 billion is going to be funded over 5 years. The thought there, like Hillary brought up, is if you just take $50 billion divided by 50 states, $1 billion of funding to each state over the course of 5 years. Well, that would be a really easy way to do that.
But it's the government, and we don't operate that way.
Different states have different numbers of people.
People, you can't make it 1-to-1.
Well, is it based off of that? What is it based off of? Those are great questions. So what they came out with is that, so the government is going to distribute this over 5 years. So year one is going to have $10 billion distributed. Of that $10 billion, half of that is going to be allocated evenly amongst all the states that applied. So right now we know that all 50 states applied. Okay. So $5 billion is going to be allocated evenly. So that equates to, if you take $5 billion divided by 50 states, $100 million each year is going to be guaranteed to each state. So
those are I mean, in theory, that number does sound hot. But when you look at healthcare for an entire state, it sounds a lot lower.
And 5 years is not a lot of time. What happens in year 6, 7, 8,
Yeah.
10, 15?
Whole new administration, someone else's problem.
Or and of you to assume we'll still be here.
Yes, exactly. So each state is going to get at least a minimum of $100 million each year.
So they did actually do that by just straight across. They did.
Yep.
They just did math that way.
They did math. They made part of it easy. Okay. The other half of each year's allocation is going to be distributed based off of CMS's statutory formula. Oh, fancy. So some of that is based off of rural metrics like population, how rural are your facilities, your population. And then the other half is kind of fluffy. So CMS will determine that based off of the initiatives noted in the state's applications. So there's a lot of like, what does that mean? What is that formula? We would like to know. As accountants, we would like to know.
Yeah.
Do we get to know? No.
Less fluffy for accountants.
Less
Is ideal.
Show me the algorithm.
Show me the algorithm. So does that matter? Yes. Do we get to know? No. But we do know what the year one allocations have been. So each state had to submit an application, a one-time application that was meant to cover all 5 years.
Okay.
So each state had their own initiatives that aligned with the RHTP initiatives that the government came out with.
So they were essentially what they were trying to do is they were writing their resume to match the job description.
Yep.
Okay.
Yep. So we'll get back to that.
Okay.
They submitted these applications in November, and then CMS determined the allocations at the end of December. So I think December 29th is when they came out. Okay. If you go back to the numbers and you do the hot math of what a fair or equal allocation would be, each state should get around $200 million each year. So I'm going to throw out some numbers for South Dakota and our surrounding states. Okay. So South Dakota's year one allocation was $189.4 million.
Okay.
So if you take 200 million minus 189.4, they're about $11 million short in that year one allocation.
So we didn't write our resume enough to match those.
We didn't do it.
Shoot.
Wyoming got 205 million.
They're better at this.
I only got it.
They got it. They figured it out.
They did. North Dakota got 198.9.
Man, we're getting schooled by all of this. Right.
Nebraska got 218.5 million. And Iowa got 209 million.
Oh, so we did not. We should have asked AI or something to do this. We didn't do it right.
We didn't do it right. No, the next round, there won't be any more applications, but maybe the next round of follow-up, there will be some AI to that.
Denny Sanford can make up the difference. I mean,
So we're essentially leaving this too, right? We're for billionaires in those states to just cover the difference.
Great question. So then you might ask, well, what happens in year two? How do they determine that? So at the end of each federal fiscal year, CMS will look back at each state's, because there will be some reporting requirements with these funds, and say, how well did you do? And what does that mean for year two? And we are going to use our smarts to decide how much states will get in the next year's allocation. So it'll be 100 million plus whatever they decide they do. So there's a concern there that if you submitted your application, like with anything, there's a budget involved with that. Sure. And you might decide in year two that you need to modify that budget, right? Yeah. CMS approved this original application, this original budget. So there's concern there. If you start changing what your initiatives or your program funding requests are, you might not get that. And if you don't get that, another state will get that.
Oh, wow. So it not only are they not having an application for year 2, they might penalize you if they just decide, nope, you didn't do what you said you were going to do. Or you want to change something and that doesn't match the way that you want to distribute this. So we're taking money away year 2.
Yep. So it's not guaranteed. And we knew that going in, but that is something that I think we'll just learn as it comes to see how much things are changing. So hopefully South Dakota is doing a great job and we get more allocation than the additional 89.
We're hoping that other states slack off and the government looks at them and says, no, you didn't do. We're going to give this to South Dakota because they really outpaced themselves.
Right. Yes. So we'll see what happens there. We will know probably in October or November of this year what that 2027 allocation will be for all the states.
So the CMS, the criteria that they are using, have they released what that will be when they look back?
Nope.
Okay. All right.
But they can. So because they're the government and they can decide what they want to release and what they don't in terms of how they did the allocations. They have released the total amount, right? That's how I got those numbers. But they haven't released how did South Dakota get to 189.4 while Wyoming got to 205.
So there's no transparency into the process of how these things.
And vague, so maybe we'll get more later. Okay. Maybe it'll be after the fact, which doesn't help either. So.
You know, because if it's kind of set, that it's set, and you know.
Kelly, we need you to go work for CMS for a whole
I don't want to
and report back.
You don't work for CMS? It's so weird.
I mean, our state representatives are actually great to work with. So there's been a lot of webinars and stuff that CMS has put on, the state Department of Health have been putting on. So there's a lot of information out there, and we appreciate that.
Oh, yeah.
I think for those of us in the healthcare accounting world, we're kind of getting flashbacks to the provider relief fund time frame. And so everybody's very interested in the information and on board with learning because we don't want to be behind. Try to keep up. That's where we're at.
Yep.
Okay.
All right. So kind of to go back a little bit, when CMS did come out with this RHTP fund, they have their own strategic goals. So what does that mean? Like rural healthcare, could mean a variety of things. Is it just rural? What is rural?
Right. How do you define rural?
Has anybody defined rural? No.
So they're just it's a small town and it's not near enough population centers, and so therefore it's rural. So there's no it's this population or it's this location. Correct. There's nothing. It's just rural.
So maybe our urban,
the vibes.
There's concerns that maybe our urban areas will also benefit from these funds, which is very much true. Yeah. So anyways, it's not defined. But the goals that CMS came out with, the first one was to make rural America healthy again.
Okay.
So you do that acronym.
I like Skeletor.
See, I was going more with a raha. All right. Sustainable access, workforce development, innovative care, and tech innovation. So the goal there is really to say, how do we provide health care to our rural communities and our rural people? How do they get access to health care? How can those facilities have the right technology, programs to provide health care? That sounds really nice, right?
It does. It sounds beautiful. I mean, I'm here with that concept.
But with any grant program out there, we are making the rules as they go. So it is hard to determine at this point how rural facilities will truly benefit from these funds. Where do these dollars actually go?
What does workforce development actually look like? So you have very nice sounding initiatives with not a lot of actual, this is what we mean when we say that.
So when they came out with these strategic goals, obviously there's a lot of verbiage in those goals out there and what states were doing to make sure they were trying to get as much funding as they could. When they wrote these applications, they were trying to use the keywords that the CMS came out with. So telehealth is listed a lot there, and that's one of the goals that South Dakota has too. But they're making sure they're putting those fluff words in those applications to see if that will incentivize more money coming to the state.
Like a guessing game of like, we think this is what they mean, and we're going to pepper in through our application these words that we think is their priorities.
Good game. That's a good, we're all trying to play this game. But there's been some critique that have come out from states that are those initiatives really providing the benefit to the rural communities in that state, or are they just trying to get the funding?
So is it actually helping the rural areas?
And we're not even there. I mean, we're still in like the baby stages of this whole program. So more to come of that. All right. So my last comment on that is that when CMS did come out with this funding, they had made certain comments like, this will allow us to right-size the healthcare system. So it's not meant to be a Band-Aid for the Medicaid cuts, but it'll help us to right-size. Unfortunately, and this is my opinion and similar opinions to some of our rural states, is what does the term right-size healthcare mean? That can mean downsizing your service lines because they're not profitable. How does that help if you end up having to provide less healthcare because something's not profitable, but it right-sizes your facility to become profitable? But put that in quotes, but
But if it still is a service that your rural residents need, even if it's not profitable, and you've cut that, then where do they go to get those services?
So that's a great question. There have been a couple of states that have come out with this specific concern, like Montana has, North Dakota, where they say, one of the maybe funding opportunities is to change your designation with Medicare, Medicaid. So we have critical access hospitals that are meant to service rural areas. That means that you have an emergency room and an inpatient, outpatient services.
Right.
There's a new designation called Rural Emergency Hospital. So that changes you from providing inpatient services to only providing an ER and outpatient services.
Oh, wow.
And you're like, that. It's actually okay because like the funding there is going to help improve that. That doesn't have anything to do with RHTP, but it is like a change that RHTP could help fund that change to that new designation.
Okay.
Unfortunately, the concerns with that is if you have a small community and you take away an inpatient part of a hospital, where are those residents going to go? They're going to have to go elsewhere.
Hundreds of miles.
And why would people move into this small community if you don't have the right hospital care?
Right. So your healthcare system, essentially, your options are, I can go there if I have an emergency.
Yeah.
And if I need just preventative care or anything else, I might have to drive hundreds of miles.
If I need a surgery, if I'm pregnant and I want to deliver a baby, I might have to. So if I'm choosing where to live, I might choose somewhere that has access to healthcare.
Yeah.
And isn't that the goal of this? Access to healthcare. But if right-sizing a healthcare system means downgrading your service lines, how does that equal improving healthcare?
Right. So that's not really access if you suddenly have less access.
It's improving healthcare profitability.
Yes.
Right.
So-
Right.
It looks good on paper, maybe.
Yeah.
Is a little icky feeling to.
And is that sustainable to the community
Right.
after 5 years is done? So that's a concern that people have brought up, and I tend to agree with that because we do, at Casey Peterson, we do work with a lot of our rural facilities, both in South Dakota, North Dakota, and Wyoming, some in Kansas and Nebraska too. So we try to advocate where we can or just try to understand the concerns that they're going through. So I think that's a valid concern.
Yeah.
It'll be interesting, once we get to year 6, how that is actually playing out.
And now the legal stuff. This podcast and associated communications are intended to provide general information about tax, finance, investment, and other financial matters. Although Casey Peterson Ltd. has made every reasonable effort to ensure that the information provided is accurate, we make no warranties expressed or implied. Be aware that this is not a comprehensive analysis of the subject matter covered. It is not intended to provide specific recommendations to you or your business. Advisory services offered through Vantex Planning Partners, Inc., a registered investment advisor. Securities may be offered through a Cetera Wealth Services, LLC, member FINRA, SIPC. Additional advisory services may be offered through Cetera Investment Advisors, LLC. Cetera named entities in the Vantex Planning Partners, Inc. are affiliated 3390 Asbury Road, Dubuque, Iowa, 52002, 563-582-2855. Check your financial professional's registration status on brokercheck.finra.org and or advisorinfo.sec.gov. Cetera named entities and Avantex Planning Partners, Inc. are independent of and unrelated to Casey Peterson, Ltd.
Hey, Hillary.
Hey, Evan.
What was the doctor's advice when I told him that I broke my arm in 2 places?
I don't know. What was it?
He told me to stop going to those places.
Good one.